The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Susan Swedo is formerly the Chief of the Pediatrics and Developmental Neuroscience Branch at the National Institute of Mental Health. Dr. Swedo and her NIMH team were the first to identify a new subtype of pediatric OCD in which symptoms are triggered by antibodies produced in response to infections with group A strep. The subgroup is known by the acronym PANDAS. If you have questions, please type them into the questions section now and throughout the talk. She'll answer as many as possible at the end. These talks are made possible by generous donor support. If you'd like to contribute, please visit our website at autism.org. And now I will turn it over to Dr. Swedo.
Thank you, Denise. I really appreciate the opportunity to speak with everyone today and into the future with this webinar being archived. It's really a wonderful advance of technology. As had been advertised, my topic today is Pediatric Acute Onset Neuropsychiatric Syndrome, or PANS, and Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infections, or PANDAS. I remain affiliated with the National Institute of Mental Health, but they are in no ways responsible for the content of my talk today, nor is the PANDAS Physicians Network, of which I serve as the Chief Science Officer. We're going to try and address 5 questions today, the first of which is, what exactly are PANS and PANDAS? Who does it affect? How can we make the diagnosis? And this is probably the most important one to me and my colleagues, because we're really very interested in early recognition and early diagnosis and treatment so that children have minimal periods of dysfunction as well as a greater likelihood of recovery and complete remission of symptoms. As we go through the talk, there's going to be some pieces of it that point to PANDAS as a form of autoimmune encephalitis, and so we'll go into that in a bit more detail than may be useful to some of you, but hopefully for those of you who are primary care providers or even parents of children in whom you suspect an immune dysfunction in your child, this might be a helpful section. And then finally, we'll just briefly touch on the 3 mainstays of treatment: the use of antibiotics, immune modulating treatments, and standard psychiatric treatments such as medications and cognitive behavior therapy. Within the universe of obsessive-compulsive disorder and tic disorders, there are a small number of children in whom symptoms overlap with the eating disorders, and that includes avoidant and restrictive food intake disorder, or ARFID, as was described in DSM-5, but also classic anorexia nervosa and bulimia. We're going to mostly focus today on PANS-PANDAS. So about 1% of prepubertal children and up to 2% of adolescents meet criteria for a diagnosis of obsessive-compulsive disorder. Tic disorders are much, much more common, and simple tics such as an eye blink, throat clearing, or other simple motor or vocal tics can be present in up to 20% of children. So if you take that entire universe of individuals, these disorders are fairly common. In contrast, PANS, acute onset neuropsychiatric syndrome, is much less common, affecting about 1 in 4 children with obsessive-compulsive disorder and an unknown fraction of those with tics. Within the PANS subgroup, then a specific type of PANS is PANDAS, and we're going to get into more detail on that. But the circle there is meant to represent that about 2/3 of the prepubertal cases of pediatric acute onset neuropsychiatric syndrome are probably triggered by strep and therefore would meet criteria for PANDAS. Now, if you look at the overlap between autism and OCD, you've heard many talks on that in the past and are well aware of the fact that the core symptoms of autism bear remarkable similarity to the obsessions and compulsive behaviors of individuals with OCD, in that the children are upset when their rituals are prevented. They often feel compelled to move forward with them. If you are speaking with a verbal individual with ASD, they can tell you that they don't have as much control over those behaviors as they would like. And that overlap has been known for a very long time. And the good news is that if obsessive compulsive symptoms occur in an individual with ASD, they're just as treatable as if they were in a neurotypical patient. So again, you have overlap between that autism, OCD, and a group of children with acute onset symptomatology, as well as PANDAS. And I apologize that those circles are behind. They should have been in front. But what it's meant to show you is that it's a relatively tiny fraction of individuals with ASD who will also meet criteria for PANS or PANDAS. Well, what are they? OCD, as we know, is recurrent intrusive thoughts or images, everything from worries about dirt, germs, contamination, to terribly violent or sexual imagery. And those thoughts may be linked to or completely independent from a set of repetitive and unwanted mental or physical behaviors. So we have children who might need to wash their hands because they worry that their hands are dirty, but we also have children who do hand-wringing stereotypic behaviors in a compulsive fashion without any concern for contamination. We've already defined PANS and PANDAS, but I want you to notice that the syndrome is highlighted on PANS and disorder is highlighted on PANDAS. These two terms are actually quite important to differentiate. PANS, or Pediatric Acute Onset Neuropsychiatric Syndrome, is a collection of behaviors and signs and symptoms that hang together without any regard for etiology or disease mechanism. In contrast, the disorder of PANDAS has a very specific cause, disease mechanism or pathophysiology, and presumed treatment. For both PANS and PANDAS, they are defined by their clinical presentation. Let's start with the broader category of PANS, and you'll notice there that it's just the abrupt onset of OCD or acute eating restrictions, here summarized as anorexia, but they may or may not have the body image distortions of a typical anorexia nervosa. In addition to the OCD or eating restrictions, the children need to have at least 2 of 7 categories of dysfunction. Anxiety, particularly separation anxiety, happens in over 90% of the patients. Behavioral developmental regression is also extremely common, varying between about 85 and 98% of the patients. Emotional lability, those extreme mood swings where the child is happy one moment and crying without provocation the next, or depression to the point of suicidal ideation. Irritability, aggression, or severely oppositional behavior. And they can already hear the questions coming up. Okay, how do we separate this from the aggression and rage outbursts that we might see in an individual with severe autism? Well, the answer is that this behavior would be coming on in concert with these other symptomatologies. For a neurotypical patient, you're going to see deterioration in school performance, handwriting changes, changes in memory, short-term memory, visual spatial skills, a large number of neuropsychological deficits that have a very abrupt onset at the same time as that OCD or eating restriction. Sensory or motor abnormalities, again, tremendous overlap with autism, but here the sensory and motor abnormalities come out of the blue, start without warning, and again, happen in concert with other symptomatology. Probably the most useful category is actually that final one, somatic signs or symptoms, especially an acute onset of insomnia to the point where the child's now only able to sleep for 3 or 4 hours a night. Urinary symptoms, we're going to go into those in more detail in a moment. And our third criterion is the fact that these symptoms cannot be better explained by a known neurologic or medical disorder, particularly Sydenham-Chorea, Tourette syndrome, and other forms of autoimmune encephalitis. So if you can find an anti-NMDA receptor or other autoimmune encephalitis, that would be the diagnosis that should be made rather than PANS, which is again just a syndrome, just a collection of symptomatology. In contrast, the criteria for PANDAS require an association with hard neurologic abnormalities, either choreiform movements, the presence of new severe tics, or the sensory sensitivities, as well as evidence of close exposure, a sibling or a parent who has had a strep infection in the days or weeks prior to the onset of OCD or tic disorders in this child. That temporal relationship can be difficult to establish in that initial episode, but usually by the time the child is seeking clinical care, if you check a throat culture at that initial presentation, you'll often find it positive, and treatment can dramatically improve symptoms, even if it's just treatment with penicillin for the group A strep. So who does it affect? This is a disorder of young children, and I get asked all the time, what about PANDAS in adults? And my answer is, I don't know. I'm a pediatrician, and we have only studied this disorder in children and teenagers. And among that group of patients, we know that this is presenting at an unusually early age. The typical age at onset for non-PANDAS OCD is actually somewhere between 10 and 14 years of age, whereas our average age of onset is about 7 to 8. Typically, the child has been in school or preschool at least a year, and it's happening in that second year during the winter months when strep is so common. It appears to affect all socio-demographic groups, all races and ethnic groups. There are increased rates in families who have a history of acute rheumatic fever, a strong family history of autoimmune disorders, and or a family history of obsessive-compulsive disorder or Tourette's syndrome. Okay, again, we go back to that universe of all childhood onset OCD and tics. That's the background, and we see that PANS is the cases who have an abrupt onset, literally defined as from nothing to maximum in 24 to 48 hours. And there are two ways that those symptoms can be triggered. We're going to focus this talk on the infectious triggers, but non-infectious triggers are very important and must be considered, and the most common of these is actually some form of abuse, either witnessing domestic violence or actual physical or sexual abuse of the child themselves. If we go back to that infectious trigger, the first kind of PANS that was described was actually called PITANS, Pediatric Infection-Triggered Autoimmune Neuropsychiatric Disorders, and that was published now more than 20 years ago as a series of cases who had a very abrupt onset of obsessive-compulsive symptoms following strep infections, but also following influenza and chickenpox. So we've known from the beginning that strep was not the only trigger, and that's one reason that we've moved from talking exclusively about PANDAS to talking about the larger cohort of children who have symptom onset after a viral infection or another trigger. For the group of children who have group A strep as their trigger, the prototype disorder is Sydenham chorea. And the context for looking at Sydenham chorea was that back in the 1980s, so now more than 30 years ago, Dr. Judy Rappaport at the NIMH and Dr. Michael Rutter in London were both looking for medical models of childhood onset OCD. Unlike their colleagues who believed that OCD was the result of punitive toilet training, Judy and Mike both knew that this was a brain-based disorder that was so severe and so unusual in the behaviors and the thoughts that the children were having that it had to be coming from a very specific neural circuitry. Work done in animals by Alexander DeLong and Strick had shown that there were 5 parallel circuits through the basal ganglia, and the one that seemed to be fit best with OCD was actually abnormalities of the orbital frontal cortex through the striatum. In humans, that's called the basal ganglia. It includes the structures of the caudate, the putamen, and the internal segment of the globus pallidus. Then through that globus pallidus, either through a direct or indirect pathway, providing feedback onto the thalamus, and then back to the orbital frontal cortex. So this is a closed loop, but depending on which way you go in the basal ganglia, it really influences the symptoms. And the reason that Sydenham chorea was seen as the best example is that pathology reports from as early as the 1920s had shown very specific inflammatory changes in the caudate, the putamen, and those basal ganglia structures. There was neuroinflammation throughout the brain, and indeed patients would have an encephalopathic presentation, but the primary site of abnormality lay within the basal ganglia. It's important to note that in Sydenham chorea, the lag time between infection and the onset of those writhing dance-like movements can be as long as 4 to 9 months. So it's always been presumed that the strep infection was a necessary trigger, but that there may be an intervening step that resulted in the behavioral and neurologic symptomatology. Well, the relationship of Sydenham chorea to OCD actually goes back even earlier than the 1800s, shown here with Sir William Osler. Thomas Sydenham, in his first reports back in the 1600s, described repetitive behaviors of these children, and Sir William Osler not only described these perseverative, repeated behaviors, but also that the parents were reporting that the child was changed. Overnight had been they didn't use possessed back in those terms in the same way we did, but they actually described their children as having been possessed. In the 1950s and 60s, a series of studies showed that in adults with a history of Sydenham chorea, they were more likely to have what we now know as OCD, and one retrospective and 2 prospective studies at the National Institute of Mental Health showed that about 2/3 to 3/4 of the patients with Sydenham chorea had had an abrupt onset of obsessions or compulsions that were identical to those we were seeing in non-PANDAS, non-Sydenham's OCD. And very importantly for this model, those obsessions and compulsions started about 2 to 4 weeks before the chorea began. Later, our colleagues down in Sao Paulo, Brazil, documented in their very large rheumatic fever clinic that somewhere between 1/4 and 2/3 of their Sydenham chorea patients had OCD symptoms at their first episode. In contrast, none were found in rheumatic fever that had only heart disease. The brain absolutely had to be involved. And they also showed that with multiple episodes, that the OCD symptoms were present in 100% of the patients and were often chronic and treatment refractory. In the 1920s, a series of elegant clinical case presentations were written, and this is one from the Journal of the American Medical Association from 1922, in which case number 2 had not only had the abrupt onset of chorea, but she had that personality change, became disturbed, excited. She was threatening suicide. I think she actually had true suicidal ideation, as many of our PANDAS patients do, and she had food restrictions. She was refusing to eat because she thought her food was contaminated with feces. Case number 4 actually had psychotic symptoms. She had hallucinations where she would see mice and moving objects in her room. She saw a man climbing through her window. These were real enough to her that she would scream with fear, and she too had to be tube fed because she thought her food was poisoned. Not all patients with PANDAS develop the fear of contamination leading to food intake restrictions. Some of them have a fear of vomiting or choking, and others will actually have a fear of becoming fat or of gaining weight, and they have a more typical anorexia nervosa presentation where they have both the body image distortions and the refusal to take in adequate calories. Well, the disease mechanism for Sydenham chorea has been extrapolated to PANDAS, and research over the past 2 decades has documented the veracity of this extrapolation, in that there are certain strains of group A strep that in a genetically susceptible host, somewhere between 2 and perhaps as much as 5% of the population, is vulnerable to the development of rheumatic fever. So it's the wrong strep in the unlucky child that through the process of molecular mimicry leads to a misdirected immune response. The antibodies that are produced are actually appropriate, although they may be somewhat exuberant, and they are produced against the strep. But unfortunately, the antigens on the strep closely resemble those of the human host, and it results in an inflammatory response in the joints for arthritis, at the heart for carditis, and in the brain for Sydenham chorea and for PANDAS. Well, I said I'd tell you what this looked like, and you heard just from the clinical criteria that comorbidities are extremely common, in fact, that they're the rule rather than the exception in these patients. And in fact, they are so common that if you had a child present even with an abrupt onset of OCD only, I would not be thinking PANDAS. We had one girl who had a very abrupt onset of hand washing and excessive genital scrubbing, and in her case, she had been sexually abused. She had none of the other symptomatology that we would have seen in PANDAS. So again, PANDAS, like PANS, is a disorder not just of the abrupt onset of OCD, but of multiple symptoms of dysfunction. And in fact, when we look at our large populations of patients now, about 1,000 children have been studied at the consortium sites across the United States, we know that on average, those children have combinations of symptoms that affect the cognitive domain, the behavioral domain, the emotional domain, neurologic, as well as somatic, and you need to be seeing them all around the circle. Further, on average, the children have 5 of the 7 categories represented. So they're going to have anxiety plus emotional ability, plus irritability, plus developmental regression, sensory or motor abnormalities, as well as that urinary frequency and sleep difficulties. The urinary symptoms are unusual. Many people think that in anxiety disorders, it's common to feel like you need to go to the bathroom often. It's not like that for our patients. They might worry that they won't be able to get to a bathroom as one of their obsessions, but we're talking true urinary frequency and that the child needs to void 10 to 20 times an hour. They often feel like they need to void again as soon as they've used the bathroom, and that may just be because of the control of the urinary system, so that they're trying to maintain continence with their external sphincter only. They also do develop an abrupt onset of bedwetting or daytime urinary accidents, and this might be in a 10, 11-year-old child who's previously been dry since the age of 3. So quite unique, and for the primary care providers, it's important to go ahead and do a urinalysis. You wouldn't want to miss a urinary tract infection, but typically the UA and even the urine culture are both negative. Sleep problems, they have an abrupt onset, as I said, of extreme sleep restrictions. Again, these are common in individuals with autism spectrum disorders, but this would be an ASD child who had previously slept well through the night and then suddenly you couldn't get them to sleep until 10, 11, 12 at night, and then they wake up too early in the morning. Or the parent might need to sleep next to them, rubbing their back, doing all kinds of things to try and get them to fall asleep. The parent often would fall asleep even before the child did. Once they do sleep, it's often restless and they move about. We think we have the explanation for that, and I'll talk to you a little bit more about that later. But it appears to be related to the abnormalities during REM sleep. Sensory issues are common, not only the hypersensitivities that I mentioned earlier, but they can also have a hyposensitivity, an abrupt onset of a decreased responsivity to cold or to heat or pain. But much more common is the children who develop acute light sensitivity, sound. They are the ones who, in association with the abrupt onset of obsessions and compulsions, will have to suddenly stop wearing clothes entirely because the waistbands are too tight and the clothes don't feel right on the skin, or maybe they're able to wear the same pair of pajamas for months at a time. They might have excessive pain, particularly an arthritic or arthralgic type of pain. Autonomic dysfunction is suggested by the dilated pupils as well as the urinary tract abnormalities. And then that fight or flight kind of hyperarousal, hypervigilance is quite common in the very early stages of illness. And we haven't accumulated a large enough sample of subjects tracked forward over time, but retrospective review of their medical records suggests that these symptoms last somewhere between 2 and 6 weeks, and that after that, the longer lasting symptoms would be things like the sleep, the OCD, the tics, and the other neuropsychiatric symptomatology. Dysgraphia can be used to track this child's illness. Let's say that you're evaluating him when he's 11, 12, 13, and the parents have access to the school journals as well as medical records. One of my fellows did this exercise for 20 of our subjects and found a one-to-one correlation between periods during which the handwriting had deteriorated, as you see in the right-hand panel, and an association with strep in that child or in one of their siblings. Tanya Murphy at the University of South Florida has administered the Ray Osteris complex figure test to more than 100 of her subjects and has found that more than 80% of the children score below the first percentile for the COBI task. Now, the Ray Osteris is actually a task of working memory, and the real test is to reconstruct this complex figure 5 minutes later from memory. The children don't score as badly on that as they do on the one-to-one visual representation of looking at the figure and then trying to copy that in the same space and same spatial relationships. You might see a patient with unusual margin drift. I didn't put it in this slide deck, but we now have a few examples of children who actually fail the clock test, where you actually ask them to draw an old-fashioned analog clock and put the numbers on, and what you see is everything is squished over to the right. Both the margin drift and the left-sided neglect are a symptom of right-sided brain abnormalities, and again, might be found with EEG or other testing. Well, all of this is spelled out in exquisite detail for you in a consensus statement that came from the PANS Collaborative Consortium. This shows shows 2014 as the publication date. That was when it was published online. But if you were going to reference it, you should put the Journal of Child and Adolescent Psychopharmacology from February of 2015. There was a special issue on PANS that included not only these recommendations for diagnosis, but also a number of papers describing additional details about the clinical presentation of these children. Very important that if you are making that diagnosis of PANS, that you pay attention to that third criterion. These symptoms cannot be better caused by another known medical or neurologic disorder. At the top of the list is actually lupus. It is rare, but when it's missed in a child, it can be extremely severe, and so it's important to look for lupus, perhaps have the child evaluated by a rheumatologist, who would also be able to look for steroid responsive encephalitis with thyroiditis and some of the other much less common syndromes, including Sjogren's, Behçet's, and antiphospholipid antibody syndrome. Multiple sclerosis in the prepubertal age child is not common at all, but you may be evaluating this child when they are now a teenager, age 14, 15. You would need to look for that, as well as central nervous system vasculitis. Guillain-Barré in a typical presentation should not be confused with PANDAS, but in some of the atypical presentations that have been described, Guillain-Barré can start with neuropsychiatric symptomatology only. Much more common would be that the child actually has a different form of autoimmune encephalitis. So let's talk for a minute about what that is. Autoimmune encephalitis is a very complex set of brain disorders, and every year there are additional diagnoses added to this family. They're all characterized by the presence of autoimmune-induced neuroinflammation, typically mediated through autoantibodies, but sometimes it's actually not. It's cell-mediated rather than antibody-mediated, and so additional testing would be needed. Among those in which you can find antibodies, it's only about half of the patients, and the determination that the child or the young adult has autoimmune encephalitis actually depends entirely on the clinical history and the physical examination, because if you depend on antibody testing, you're going to miss half of the cases. However, those antibody-negative cases are more difficult to diagnose because you really don't have any confirmatory lab assay, and therefore it's diagnosed on the basis of three things: the clinical presentation, being typical for other previously described cases, abnormalities on paraclinical studies or lab assays, and the third, and the one that's usually used as the diagnostic test, is how does the individual respond to immunomodulatory therapies. Well, if we ask the question, is PANDAS a form of autoimmune encephalitis, it certainly fits the category in terms of clinical presentation. You have a very abrupt onset of symptoms in multiple domains across cognitive, emotional, behavioral, sensory, motor, and somatic. You have memory and concentration difficulties. You have documented neuropsychological abnormalities on tests of basal ganglia function as well as frontal lobe function, handwriting changes. We discussed the left-sided neglect as sort of a hallmark symptom of encephalopathy, insomnia, the urinary symptoms, and then those neuropsychological deficits. The paraclinical support comes from a lumbar puncture, spinal tap, which yields cerebrospinal fluid that might show pleocytosis, not in an increased white count, but in the presence of atypical lymphs on a flow cytometry. So the cell population has changed and is indicative of a neuroinflammatory process. The possibility the child will have an abnormal IgG index where they have either depletion or excess of immunoglobulins within the CSF. The presence of cross-reactive antibodies that are present in higher titers during acute illness than they are during convalescence. That work in PANS and PANDAS has been done by Dr. Madeline Cunningham at the University of Oklahoma over the past 15 years and has nicely documented that in PANDAS, just as in Sydenham chorea, both serum and CSF are positive for cross-reactive antibodies during the acute illness, and these decrease over time. MRI and PET might be used to demonstrate basal ganglia inflammation, and most clinically useful are the presence of abnormalities on electroencephalography or polysomnography. So a study done by my colleague Jay Geed and our group documented that there were volumetric differences in the size of the caudate, the putamen, and the globus pallidus among a group of children with PANDAS, OCD, or tics, and compared with not just a group of healthy controls, but compared with children who had non-PANDAS OCD or non-PANDAS Tourette syndrome. These abnormalities were not present in overall brain volume or in the thalamus. However, for your purposes, this is just an interesting research note because clinically, the number of children who have discernible different size abnormalities in PANDAS is quite small. It is extremely rare, so I'm not sure it would be worth it to do an MRI just to look for volumetric changes. However, doing MRIs with contrast to look for slowing of the decay across the venous system might be useful, as has been described in multiple sclerosis for detection of regional inflammation. This is the one patient that we were able to document a visible size difference during acute illness. The head of his caudate was 20% enlarged over expected for age, sex, and weight, and following successful treatment with plasmapheresis, it had normalized. Dr. Shugani and his colleagues at Wayne State University utilized a marker that recognizes activated microglia, and they're presumed to be a proxy for inflammation within the brain, and the arrows point to an increase in uptake within the head, right caudate, right lentiform nucleus in the patient with PANDAS that was markedly greater than that was seen following successful treatment with IVIG. For this study, the caveat is the fact that the Wayne State group actually found increased inflammatory markers in patients with non-PANDAS Tourette syndrome. However, they weren't present in the caudate. And, of course, the fact that PET utilizes radioactivity and radioactive markers and is not generally indicated for use in children. Electroencephalography yielded results in about 17% of our patients. This fraction was the same as we had seen in Sydenham chorea, and the findings were similar in that we had 4 children with spike or sharp and epileptiform abnormalities. Those are indications of brain inflammation and brain neuroirritability. In contrast, nonspecific diffuse or focal slowing is an encephalopathic change that is seen in other disorders such as Sydenham's and the other chorioathetoid disorders. Polysomnography had a much higher yield, and if I had to choose just one test that would be done in that child in whom you're not sure whether or not immune therapy is required, I would probably try to get a polysomnogram, particularly if that child had a history of restless sleep or new difficulties with insomnia. because in our small study of 12 children, we found that 4 of them met full criteria for REM behavior disorder, and 6 had non-specific REM motor disinhibition. What this means is that during REM sleep, rapid eye movement sleep, when your body is supposed to be completely paralyzed or atonic, these children are not, and they continue to move about, to thrash, to moan, laugh, or even do stereotypic behaviors of their hands and fingers during the REM sleep. In older adult patients who have Parkinson's disease, this is thought to be a poor prognostic indicator, but it doesn't appear that it is indicates a poor prognosis for PANDAS, as it appears to be present only during acute illness. A replicative study at the NIMH and work done at Stanford by Dr. Jenny Frankovic both suggest that these abnormalities are present during acute illness and may disappear with effective treatment. So we get back to our question of, is PANDAS a form of autoimmune encephalitis? I think there's strong evidence from the clinical presentation, from the paraclinical support. So the final piece is, does it improve with IVIG or plasmapheresis? And the answer is, yes, it does. It does improve with steroids, IVIG, or plasmapheresis. By now, this slide is so old that you guys all know it as well as I do. What it shows is that in a group of children who received active intravenous immunoglobulin or 5 single volume exchanges of plasmapheresis treatments, that they had a dramatic improvement by 1 month in obsessive-compulsive symptomatology. In contrast, those children receiving placebo IVIG in a manner identical to the active treatments had absolutely no symptomatic improvement. I need to point out that a subsequent replicative study at the NIH failed to find a detectable difference between IVIG or placebo. Personally, I think that part of that reason was because of some flaws in the study design, but the reality is that the literature, the extant literature currently is divided between this study and one in which the IVIG was not as effective. The reason that this is important for you to know is that these findings, in combination with the current statement in the AAP's Red Book on infectious diseases, includes a very damning paragraph about PANDAS that says that the disorders, there's no evidence that strep is a trigger and no evidence that antibiotics or immune therapies are needed. And some insurance companies point to that as the standard of care. In turn, you can point them back to the treatment guidelines, and I'll give you those references in just a moment. So I believe that it may be time, as Dr. Russell Dale, who's now in Sydney, Australia, has suggested, to, quote, rebrand PANDAS as autoimmune encephalitis of the basal ganglia, or even post-streptococcal autoimmune encephalitis of the basal ganglia. We have good evidence for that, and it might actually take it out of the field of controversy and put it into a place where it could get treated better. But in the meantime, ICD-11, which is currently in use in Europe, has already recognized PANDAS as a form of an autoimmune movement disorder or other autoimmune neurologic disorder. So again, making the diagnosis, you should turn to the Journal of Child and Adolescent Psychopharmacology, January, February of 2015. The medical workup needs to be comprehensive enough to rule out all those other things, and so it would be a physical exam, looking for choreiform movements, certainly looking for chorioathetoid movements. If you have any evidence of chorea, the diagnosis of Sydenham's is much more appropriate, much more acceptable, and certainly warrants treatment. Swallowing study, if obsessional symptoms occur, we had 2 of our patients with Sydenham chorea in whom they had an abrupt fear of eating for fear of choking or vomiting, and in both cases they had dysphagia on their swallowing study. If the patient doesn't have symptoms involving swallowing, then I don't think you need to bother with the swallowing study. And we've already talked about the importance of polysomnography, electroencephalography, and lumbar puncture. Throat culture absolutely needs to be done in every child presenting for treatment for PANDAS. I can't tell you the number of kids who've had symptoms for months. We do a throat culture. It's still quite positive, and treatment with antibiotics of that positive strep culture is sufficient to help improve symptoms. A perianal swab may be indicated, and certainly for the primary care providers, please do it before you refer that patient to a psychiatrist or psychologist, because they'll just have to send them back to you as that's not part of their practice. Anti-streptococcal titers, I'll just take you to the bottom line. I don't use them very often anymore because it's very hard to find the child in that period before the titers should have increased. And once you have positive titers, all you know is that that child has had a strep infection at some point in the past. It may be that that point in the past is related to the onset of the neuropsychiatric symptomatology, but it's much more likely that it's not related to that, and it's just a hangover from the strep infection they had the previous winter. More useful might be doing anti-nuclear antibody titers. They are present and positive in about 5 to 10% of healthy children, but 56% of kids in the NIMH cohorts have had positive titers. That's about the same rate as we found in Sydenham, Korea, where it was 60%. And if you are able to obtain the Cunningham panel, the combination of a positive ANA and a positive CAM kinase 2 was a really strong predictor of response to IVIG, excuse me, in our most recent trial that we did in collaboration with Yale University. The molecular lab assay is I believe listed as a diagnostic assay. I consider it to be more of a confirmatory lab test, and autism is one of the reasons why it can only be confirmatory for PANDAS, and that is the fact that it may represent just gross brain pathology, as Dr. Cunningham did a study in a large cohort of children with non-PANDAS, no history of PANDAS-PANS, but a history of autism spectrum disorder, and found increased rates of positivity on several of the antibody markers in that in the Cunningham panel. The CAM kinase 2 activity was not markedly increased, so again, that may be the best part of that test to be useful in terms of what are we going to do next. So how is PANDAS treated? 3 things, and 3 very simple legs of the stool. First is you need to treat the source, and the only treatable source is a bacterial infection. If the child has had a viral infection, antivirals will not be helpful at the point that they are having the neuropsychiatric symptomatology, because the virus has been self-contained by that point in time. You want to treat the immune system dysfunction and then treat the symptoms. Let's go through these. As I mentioned, this was written up in the Journal of Child and Adolescent Psychopharmacology. And as we go through the 4 papers that were part of the consortium's treatment recommendations, you may notice that there are over 40 authors from 20 different medical institutions, all of whom contributed to these treatment guidelines, and they actually took more than 18 months to come to consensus on what was reasonable. I mentioned the 3 legs of the stool, and they are all equally important. The 3rd leg of that stool is treatment and prevention of infections. We put it 3rd in the guidelines because of all the things that might get missed or skipped. Antibiotic use is the one that's probably okay, because if you're not seeing that child until a full year after their symptoms begun, or even longer, then treatment with a month of antibiotics is less likely to be helpful. However, within the first weeks or even months of illness, a month of antibiotics is often all that's required for the child to return to their baseline. And so the consortium ended up recommending 3 to 4 weeks of a narrow spectrum antibiotic at the time of initial diagnosis, and the use of long-term prophylaxis only if the child fully met criteria for PANDAS, and the research criteria for PANDAS require at least 2 episodes of neuropsychiatric symptoms that had an abrupt onset following a known exposure or infection with group A strep. So you can't start talking about long-term prophylaxis with the first episode. You sort of watch and monitor, And if the child has a second strep-triggered episode, then you might consider prophylaxis. But again, you have to consider that individual's risk-to-benefit ratio of use of long-term penicillin VK by mouth or IM bicillin intramuscularly. Immune therapies are the ones that people have really latched onto as sort of the treatment of choice for PANS, PANDAS, but in actuality, they are only useful in conjunction with the other two legs of that stool. And so this group includes use of non-steroidal anti-inflammatories, ibuprofen or naproxen, oral or IV steroids, either a short course like you would use for asthma or a longer course such as you would use for treatment of outbreak of poison ivy. Intravenous immunoglobulin, it's the high-dose IVIG at 1 gram per kilogram on each of 2 consecutive days. It's very important if you're listening to this webinar live or within the end of 2019 that you know that IVIG is currently in extremely short supply, and patients who have life-threatening illnesses dependent on replacement of their immunoglobulins are often unable to get it. So if you are denied use of IVIG during this particular season, it may not be because of the child's PANS, PANDAS. It may just be because there's no IVIG available to give to them. They expect that that shortage should be relieved within the next few months, but at the current point in time is quite severe. Therapeutic plasmapheresis, as I mentioned, is 5 single volume exchanges over a 2-week period. The group at Georgetown University has been able to shorten that to a week in hospital by doing 4 1.5 volume exchanges every other day. Notice there it says, as indicated by severity, and this part 2 of the treatment guidelines actually goes into exquisite detail in helping you to determine if the child's symptoms are mild, moderate, or severe, life-threatening. Obviously, on the mild end of the spectrum, the child's still able to get to school, the parents are still working, but they're having at least an hour a day of intrusive obsessional thoughts, compulsive rituals, irritability, perhaps even some school refusal, but they're able to get there with assistance from the parents and the teachers. Moderate then is getting into the point where it's impacting school, peer functioning, functioning at home. And severe life-threatening is that child whose waking hours are completely consumed with this illness. They are life-threatening behaviors such as refusal to eat or drink, requiring tube feedings or IV hydration, or some children who have a very problematic presentation of an impulsivity, behavioral regression down to the age of a 3 or 4-year-old, and on top of that have suicidal depression. Those children would be considered life-threatening, and you need to treat them aggressively in order to shorten the course of their illness. However, if it's not PANS, PANDAS, do not pursue immune therapies. And I think this is the slide that to me I show because the most troubling and just frankly worrisome thing that I see in my consultations is children who really never had a good history of PANS, PANDAS, not good evidence of the disorder at the initial presentation to the physicians, and yet they've gotten on a long-term course of use of IVIG or other very expensive and invasive immune therapies. I think our families with autism are at particular risk of this because those children may have underlying immune abnormalities. The PANS, PANDAS hypothesis is quite compelling, and more importantly, we've talked about the overlap in symptomatology between autism and PANS, PANDAS. So as their clinician, it's really your job to help them sort through this and get through the message that immune therapies carry significant risks of side effects, and if they have no benefit, then that risk-benefit ratio is just not in favor of their use. And this study from Nicholson et al. In 2000 was done in a group of children with obsessive-compulsive disorder right after we had made those findings of how incredibly effective plasmapheresis was for PANDAS. We expected that maybe we'd accidentally found a good treatment for OCD. All 5 patients expected to have a wonderful response to the plasmapheresis, and none of them had an improvement in any of their symptomatology. A similar study was done in Denmark with IVIG for non-PANDAS Tourette's patients and had similarly disappointing results. So again, if it's not PANS-PANDAS, do not pursue immune treatments. It just doesn't help. All right, the final piece is, in our opinion, the most important, and that's actually why it was part one of the clinical management, and that's the use of SSRIs, anxiolytics, or other typical psychiatric medications, as well as cognitive behavior therapy, specifically exposure with response prevention. And that CBT needs to be administered by somebody who's familiar with treatment of OCD. If I had my choice between a therapist who had a lot of experience treating children or one who had a lot of experience treating OCD in adults, I would actually go for the treatment of OCD in adults, because treatment of OCD in children is identical to that that's been found to be effective for adult patients with obsessive-compulsive disorder. The management is actually quite complex, as suggested by the wide breadth of the symptoms that are affecting these children. You might need to use melatonin or Benadryl or something else to help them get to sleep. Neuroleptics may be helpful for severe abnormal movements. They're not typically helpful for the behaviors, even for the rage attacks. We don't use the anxiolytic medications very often, but the results of the sleep studies, as well as the severe anxiety that these children experience, would suggest that perhaps use of a long-acting benzodiazepine might be effective for these children. And the probably most important on this slide is the supportive therapy, just sort of talking about the course of the illness and supporting that tough love for the parents, where they don't give in to that need for reassurance and answer the question on the 15th time you're asked, are you sure I'm okay? Are you sure I didn't accidentally bump that vase and break it? Because all you will have done is reinforce the fact that the behavior ends up in a reward. So getting the parents into cognitive behavior therapy even before the child is ready may be useful. Final thing is how this impacts the children. A very helpful book, this one by Patricia Rice-Doran. Margot Tienemann wrote a lovely chapter in this book. There's also Planes, Trains, and Cans, a guide for parents and physicians, parents and educators, as well as some other resources. All of these are available on the NIMH website, and the PANDAS Physicians Network actually has a lovely algorithm both for diagnosis as well as for treatment, and that would probably be the first place I would go for additional resources. Denise promised me that if I kept it to about 50 minutes, which it looks like I did, then we could have a few minutes for questions, and I think she's going to come on and share some of those that you've been asking. But otherwise, I thank you for your attention and really appreciate this opportunity to speak with you today.
Well, thank you, Dr. Swedo. We do have a lot of questions. I've got some that were emailed in prior to the talk, and then quite a few that came in today. So everybody who's listening, if you have a question, be sure to type it in, and I will pose it to her. We've got quite a few that are overlapping, so I want to tackle those first. One of the questions that we had, people are asking about using antibiotics prophylactically. So I think you really addressed this in your talk, but if somebody is going to their physician and they're discussing using antibiotics for PANDAS and there hasn't been a thorough workup, what have you observed? What have you seen? Have there been cases where that's been effective? Is it hit and miss?
Yeah, I would think it's more hit and miss. There are two instances where it is helpful, and that is one in which the child has had either a recent onset or maybe is having an exacerbation at this point in time. Then following the consortium guidelines for administration of a month of antibiotics at that point might be appropriate. The reason that we decided on a month was there was evidence from Georgetown as well as other sites that the tonsils often have microabscesses containing strep that takes a long time for those to be eradicated with the antibiotics. And the second thing was the frequency of sinus infections. More than 2/3 of the patients in the NIMH sample had evidence on their MRI scan that their sinuses were enlarged, inflamed, and presumably infected. So the month of antibiotics can be useful. Prophylactic antibiotics, I know that by now a lot of folks have heard of the Augmentin addicts, or the children who, oh, he was doing so great until we tried to get him off his antibiotics. One of the issues there is the fact that all of the beta-lactams, the amoxicillin, penicillin, have immune activating activity. So does azithromycin, and probably the one who has the greatest immune properties is actually Augmentin because of the clavulanic acid. It's probably not the amoxicillin in that case, but the clavulanic acid itself. I think that the Harvard group is trying to do a trial to see if that alone might be effective, but if it is an immune effect of the antibiotic, then you actually want to get them off that antibiotic and onto an appropriate immune treatment, because the antibiotics are just causing problems that aren't necessary.
The next question is about nutrition and the GI tract related to PANS and PANDAS. So do you have any observations about how, I mean, obviously all of us, if we're eating too much sugar and these kinds of things, it's going to affect us. But has there been any good research on how nutrition might impact it, or how the GI tract is affected?
Yeah, so that research is just beginning out at the University of Arizona in Tucson. If there are any if any of you know of twin pairs in which one child has PANS, PANDAS, and the other one doesn't, please contact Sydney Rice or Michael Daines at the University of Arizona, Tucson. They are working with some basic scientists there to look at the microbiome and see about sort of microbiotic differences between that would be contributing to susceptibility. But in general, we don't believe that the microbiome plays a major role in the onset of this illness, because again, it comes on overnight, and the microbiome is quite stable until you give antibiotics. So one of our problems at the NIH and in all the sites that care for PANDAS children is that we don't really have that opportunity to know what's happening with diet, nutrition, and the microbiota, because we see the children after they've had antibiotics, and we know that that has a marked impact. Sort of trying to control for that, we do recommend use of probiotics and prebiotics during the months of antibiotic administration, and again, recommend against prolonged use of anything broader spectrum than penicillin as prophylaxis.
The next question is about tonsils. So parents are asking about removing tonsils, if that's been found to be helpful, if it's not an issue.
So the Georgetown group, excuse me, led by Earl Harley in collaboration with Beth Latimer, feels quite strongly that tonsillectomies are indicated for this cohort of patients. And in fact, Dr. Latimer now suggests that children have tonsillectomy before they have their IVIG treatment. However, the rest of the consortium is not quite as convinced on this, particularly Dr. Murphy and I, who saw a number of our initial patients who were presenting to us after having had a tonsillectomy, and they had really lost their harbinger of a strep infection. And so basically the tonsils had been doing their job of getting red, inflamed, sore, and the kid knew he had a sore throat, got the throat culture, and that detected the strep, and without the tonsils there is the warning sign the strep was missed. So I would say it's really going to end up being an individual decision, and at this time I'm suggesting to my parents that we follow the ENT and Red Book guidelines for if the child's had frequent strep infections, that might be an indication for a tonsillectomy, or if the exacerbations are always triggered by strep, certainly it's something to consider. But when that new Georgetown paper gets published, it may be that the weight of evidence swings in favor of TNA.
The next question is about the studies that looked at when PANDAS can be triggered by not a medical symptom, but by abuse. Are there studies that cite that specifically?
No, it was in the general diagnostic guidelines, and it's also in the literature if you look at old case histories where there has been abuse and the presenting symptom was excessive scrubbing. The child or adolescent would typically have other signs of PTSD, and it's not one of those suppressed memory things, you would be able to get that history. Sort of the converse of paying too much attention to it, I would say, is actually much more of a problem. Again, we've had families where the dad was accused of abuse because of the child's abrupt onset of neuropsychiatric symptomatology, and nobody thought to look for PANDAS. So we have it in the differential diagnosis, ask that it be considered and ruled out, but as soon as it's ruled out, I think you can move on and treat the child as a PANS.
All right, great. Well, thank you for spending this hour with us today. We really appreciate it. I wonder if we could ask you back again in the future.
I would love it. It'd be great. And hopefully next time I come back, we'll have lots of new evidence to share and more specific guidelines about how to be helpful to your patients.